Welcome to Acute Conversations, the official podcast of APTA Acute Care, where we share engaging conversations about acute care physical therapy so you can connect to your profession. I'm Danny.
And I'm Leo. In today's episode, we have authors from the recent JACBAR article, a clinical perspective on the value of reducing PT and OT co-treatment in acute care hospitals. We hope you enjoy the show. All right. Welcome to another episode of Acute Conversations. Today, we've got a rock star cast of guests on our show today. We've got Harley Kvenvold, Haley Bento, Kathryn Brito, Brian Hall, and my co-host, Danny Young. The subject for today's episode is talking about an article that was published in the JACBAR Journal of Acute Care Physical Therapy, a clinical perspective on the value of reducing PT and OT co-treatments in acute care hospitals. And what's great is that we've got a returning guest, Haley Bento, who spoke and was on a previous episode talking about co-treatments. And we've got some fantastic information about how popular that episode was. But Haley, let me just start off with you. What's new? You've got a new cast of people that came together to put this information out. How did this come about?
Yeah, first of all, thank you, Leo and Danny, for having us on. I think this is a really important conversation, and we're excited to get more conversations sparked and people thinking about co-treating and how we utilize that in acute care settings. So I was on this podcast about 2 years ago now, following a pretty successful presentation at CSM 2023, where we talked about the idea of collaboration without co-treatment and how we as a PT/OT team, specifically our clinical team at that time on our cardiovascular ICU at University of Utah Health, had really established some great treatment and practice patterns surrounding supporting each other, but really separating PT and OT treatment sessions to allow for focused and precise targeted treatment for our unique goals and using our unique skill sets as PT and OT clinicians in acute care. The podcast was filmed with our clinical team at the time. So PT Brian Lose, who he's still around, don't worry, he's still doing great things on the CVICU, as well as an OT that had done that presentation with us at CSM that year, Paul Arnold. Paul has recently stepped back from that position, is in a different position within our healthcare system. So with that, Harley has taken that role and been carrying the torch on the CVICU clinical team for really true clinical excellence as an OT practicing in that setting and promoting our separation, working better together, working better apart at times. And we also have a few other guests in here today. So Brian Hull is a PT manager, departmental manager down in Texas. And I met him at previous CSMs, and we had some great conversations about co-treating, about departmental policies and how to really optimize the value of PT and OT in acute care. And he's done some great work and great publications in that area as well. So when we wanted to publish this, I tried to think about who I could bring in that had some different angles here. So Brian was high on my list there of somebody that had departmental management experience and had also published in the space when thinking specifically about value. And then Katie is also in a management role out in the Chicago area. And she has previously spoken about this topic at CSM, specifically in one of the Oxford debates. It was a very fun time. So after that CSM, I reached out to Katie, I reached out to Brian, I reached out to Harley, and I said, let's put our brains together and try to approach this in a way that it will be publishable in a paper, because we need to start putting some groundwork and getting something out there published that's available to people to start building an evidence base on this topic.
That's fantastic. And compared to from the last episode, what was some of the feedback? What's some of the things that you heard about? And let me also ask Katie, you've seen the numbers. How many people actually listened to that podcast episode?
Yeah, so for those wanting to go back and listen to the episode, it was put out April 13th, 2024. And the title for that episode is Reducing Co-Treatment in acute care, why it's a necessary change for everyone wanting to go back and listen to the first episode. And to date, for Acute Conversations, it is our most listened to episode, topping out at 1,387 streams across the world, many countries. So it's a very popular episode. It still continues to be a popular episode. It's one that kind of resurfaces on social media every now and again when people start talking about co-treatment again and sharing the episode and pointing back to that. And it's Haley mentioned that putting out this article was important to start those conversations. And I think so far we've been pretty successful with that because there really was nothing in the literature talking about co-treatment between OT and PT in the acute care setting.
And I think the popularity of the podcast, as well as personally, like my success after that wildly popular CSM presentation, we got invited to do a webinar for the Health Systems Council. We have gotten invited to speak with several different health systems across the country that we've done kind of a variety of lunch and learns and in-services, as well as people just pretty frequently reaching out to ask how to problem solve some of this with their staff in various healthcare systems. But the popularity of this really speaks to the fact that this is so prevalent and so important to acute care clinicians. It's something that every single one of us that's worked in the acute care setting has dealt with, and that people have some strong opinions about, and that practice is extremely varied. And so when we're trying to define it and categorize and talk about when it's best to use it and when we should be maybe avoiding it or reducing our use of it, it does spark a lot of conversation. And I think that's good because it's something that's needed and that we don't have a lot of guidelines or standards for.
I was wondering if I could start off with a question about why you think that this is a thing that people do and want to do, and why it then becomes a problem. Because obviously people are doing it for reasons, right? They have reasons that they do it. And I think if we start by talking about that just a little bit from your perspectives, because you've talked to clinicians and or have your own experience with that, I think it'll help us set the stage to talk about why we then need, how we can address the change that we also feel like we need. And so maybe weigh in just a little bit on what are the motivations for people who keep doing that make it something that we end up having to address as a problem too.
Brian, do you want to take that one? I feel like you've seen a lot of different clinicians come through over the years.
Yeah, sure thing. Yeah, great question, Danny. What I've seen over the years, and let's start the perspective based off of when we're interviewing new graduates coming in and are ready for practice, both occupational and physical therapists. One of the things we saw that really started to spike and take off, and these are one of the things that I would email Haley about over the last couple of years and get her perspective. And when she spoke at the CSM, that was really informative. But one of the things we would find out in the interviews is even if some of the PT or OT new graduates had a clinical or a field work, hopefully ideally within a hospital before we would interview them for hospital work, we would find that someone would say, I was restricted from seeing the COVID patients. I was restricted from here. I wasn't able to get in the ICU, or the only clinical affiliation that I was available, because a lot of the hospitals canceled some of those affiliations during the pandemic, was to have more of this lower acuity. So we would see a whole lot more of the people that we were bringing on board just didn't have the experience. So by the time you're in our critically ill population, we would have people not having the skills or the knowledge, potentially some fear, to be able to work there. And if you can partner up with your OT or your PT colleague who knows that, who has a couple more years or 5 more years or 10 more years experience, you can create a comfort zone, a mentoring opportunity. And we're all about mentoring, but it has to be, what are your learning objectives? What is the pathway to get the mentoring? And then when are we going to wrap this up? Because we have more patients than we can see every single day. And if we're doubling up on one patient, half the patients aren't seeing it. So for me, even though co-treating would kind of come up now and then, the pandemic and people's lack of clinical experience in some of the critical care is the thing that really set it over the edge. That's my perspective.
Yeah.
And Katie, you're in a different healthcare system in a different part of the country. What has been your experience with why people co-treat?
Yeah, and I think all of us did a really good job within the article talking about those variety of reasons. Because to Brian's point, lack of competency and comfort with challenging populations or unfamiliar units and things like that are often a common reason. A lot of times, management will look for a way to remain productive and efficient with their time, but also provide that mentorship or coaching support for newer clinicians by having them go in with an OT or a PT colleague to the ICU and get their feet wet and get introduced. Where that becomes a problem is where that becomes the expectation and the reliance, and clinicians lack many times that independence and start relying on, okay, we're going to go see this patient together. Or you also see commonality. Rehab departments are very close-knit departments in acute care, and everyone has their OT or PT buddy or their OT or PT spouse per se, and they want to hang out with that person all day. So they're going to go co-treat or co-eval with their buddy. That's a commonality. And I think one of the other big sticking points, we talk about nursing staffing shortages and how that actually impacts rehab staff as a whole. Not all rehab departments across the country have rehab techs or rehab aides or enough of them. So when you're dealing with a patient that requires additional physical support to safely mobilize them or to safely participate in tasks, sometimes you see departments and clinicians relying on co-treatment or co-eval to have that extra set of skilled hands. It's not always a bad thing. And that's something I think is important to point out. This article, we're not shaming co-treatment because it is a valid tool. It can be a useful tool. And we do try to outline certain scenarios and things where co-treatment may be appropriate and effective. The problem is when it becomes the culture and the commonality and the expectation across the board.
Yeah, I really appreciate you laying that out in terms of why it happens. And I think that no one's going to be surprised by that. And you do a good job of that in your paper. And then you do a nice job of moving on in the paper to highlight why it's a problem. And so I don't know if you had any comments about why it's a problem before we move on to any other topics, but that I think is one of the focuses of the paper is, why do we do it? Why is it a problem? And then what do we think we should be doing is the order of things there. So I don't know if you want to talk about any of the reasons it's a problem or highlight any of those just for the audience that may not have read the paper yet.
Yeah, I think, Harley, do you want to speak on this one? I think one of the biggest things that I see is that OT is not being utilized to their full potential when we co-treat. I think most of us would agree with that OT becomes PT's assistant and things become very much about mobility and they're just extra hands. And if I'm using an OT as I would an aide and just for their hands and their muscles and not for their brains and their training, that is a problem. Harley, I would love to hear, as an OT, as the only OT on this call, how does co-treating affect you? And you're speaking for the greater OT profession here.
Yes, I would
No
love.
pressure.
Yeah, I would love to speak on that. I think on the topic of not getting a lot of clinical experience in these areas, I came out of school during the pandemic, so that was my experience. Is I wasn't able to get a clinical in a more acute setting, things like that. And I think what it comes down to for OT and PT working with a patient at the same time is pretty much everybody knows what a physical therapist is. I still, 5 years into my career, go into rooms and at least once a day, I get the classic, oh, I'm retired, I don't need to get a job. It's just the experience of every OT that every OT has, particularly in acute care, of, okay, what is this profession? What are they doing for me? Whereas, again, everybody's heard of physical therapy. They have a decent idea of what a physical therapist might help them with. So early on in my career, it was pretty easy for me to limit my co-treating simply because it's so easy to get eclipsed by the physical therapy component of a treatment session, purely because the patient knows what a physical therapist does fairly well for the most part. And so when we go in together, again, it's so easy to eclipse with something that's more familiar than something that is a little bit more unknown, a little bit more of an enigma. People don't necessarily, I always ask, have you ever had occupational therapy before? Do you know what it is? And the vast majority of time, people are saying, no, I don't know what that is. And I'm having to give a whole elevator speech about what I can do for that person in their particular context. So again, I think, I'm rambling, but I think the main issue is the kind of diluting what an occupational therapist can do for a patient, particularly in the acute setting. And we have so much evidence that occupational therapists are integral in preventing readmissions, again, in the acute care setting. So having separate services is extremely important, A, to prevent readmissions, and B, to not dilute occupational therapy into this. I think Paul Arnold said in the last version of this podcast back in 2023 that we're not PT's little brother. We're not an aide. We have master and doctoral level training, and we have our own, great several domains of practice in which we can help. It's really about not necessarily diluting the profession and then increasing value-based care in that area. OT has a lot of value to offer. And again, I think that value just gets diluted when we're coming in together and providing an intervention that, again, the patient's kind of who's doing what here?
From that last episode, I do remember Paul really focusing on that and just, we don't want to dilute kind of what OT can bring to the table, right? And then we kind of miss out on the opportunity of multiple kind of short sessions for some of these patients that we have in the ICU and how that can become a problem. Because if you come together, PT and OT is great. You've got multiple hands that are in the pot. But out of the 24 hours of the day, that's just 1 hour that they've got both therapists. How much is that going to really have an impact on our patient as opposed to maybe a short session with one of the practitioners, OT or PT, in the morning and then later on in the afternoon? So I do want to share, there's been very strong emotions evoked when you talk to some people about co-treatment. For example, I do remember Chris Permy said, I don't need more people in the room in terms of both PT and OT. I could use more hands to kind of help out with some of the mobility. And when I've asked Heidi Engel about co-treatment, she really doesn't believe that it's ever justified to be able to take away from the patient. Now, I want to counter that with maybe there are some situations where it might be beneficial. Brian, you had alluded to that a little bit before about if you've got maybe a newer clinician that's not as experienced and so they get a little bit of that mentorship, that might be some justification. But could you all, because you had mentioned a little bit in the article, there are some times where it might be justified. But again, I like, Katie, what you had said about culturally, is this something that we're just doing just because it's a little bit more easier to do, hanging out with my OT PT buddy? And are we doing a disservice to the actual patient?
And I think there are a couple things here. There are plenty of times where I need help. That does not mean I need an occupational therapist. They're not my helper, right? So really trying to differentiate, I need help versus I need an occupational therapist and their specific skills in this scenario. And yeah, like you said, Leo, there are some very strong opinions, and you look at some of the most skilled and storied therapists in our profession, somebody like Chris Permy, and she stood up in our CSM session a few years ago, was like, I have never once co-treated. Never once. And she got a round of applause. People are like, heck yeah, because she is so competent. She's going to figure out how to do very highly skilled therapy and it's not even just that. She's competent in herself, but she's also going to allow her OT counterparts to be in their own right, do their own thing.
Hey, Harley, can you talk for just a second? Because I think that we're going to have different people listening to this, and everybody, like you say, has their own ideas about what OT is or isn't. And so because we've been talking a lot about the unique skills or the professional attributes, abilities of an OT, can you tell us what it is like when you think about these patients that you see in these critical care environments and the differentiation between what you're bringing and what your PT colleagues are doing? Can you help talk about that just a little bit for all of us?
Certainly. Yeah. I think something that I know Paul focused a lot on in his practice, and what I focus on now in my practice, is a lot of functional cognition, particularly mitigation of delirium. And I think there is of course a place for prevention of delirium, but that's I think everybody's job. So I think OT does a great job of getting in there when there has been delirium that has been identified and implementing numerous interventions, whether it be patient and family education. There's a great article by Alvarez in 2017. I think it's in our references on the article, identifying the 5 or 6 core areas that occupational therapists can intervene on that they did show made a significant difference in patients' length of delirium and then whether delirium ever even started. They did a lot of prevention as well. But going in and helping bring patients out of that delirium. And then also, if a patient is delirious for a long period of time, we know that impacts their long-term functional cognition. So identifying those issues early, remediating where we can, and then obviously it's a huge part of acute care is getting them to the next step. So what are the next steps and how can we refer out for that? In addition to that functional cognition piece, we know that unmet ADL needs are one of the main reasons for hospital readmission. So working on those ADL needs within the context of a critically ill environment not only will help remediate that delirium, but goes to start remediating those skills. So when that person goes to go home, there's a better chance that they can go home rather than another facility and then stay home. So where that's different than PT, obviously, everybody's working to make the patient a functional human, right? But we're using as OTs function as a means to an end and means and an end. And working to hopefully remediate some of those issues with cognition while also preparing them to be successful for discharge home. I hope that answered that question.
Yeah, I love that. And I love how you talked positively about what an OT does. I think too often we talk about what we don't do in order to define who we are, and your positive explanation of what you offer, I think was really helpful. So thank you for that.
So I will say that after interviewing y'all for the podcast last time, you all changed my practice, right? It really made me kind of take my practice, put it on the microscope. When do I co-treat, right? How often do I co-treat? And is there a legitimate reason rather than just my comfort or just my convenience to co-treat? And so what I did notice is after that, we recorded last year, people would come up to me and say, hey, I'm going to see this patient at this time, or what time are you going to see this patient? But I would kind of skillfully just say, oh, why don't you work with them right now? Or I'll work with them first, and just kind of like softly kind of give that message. But it definitely changed my practice. So what I wanted to ask the group here is, has this changed in terms of your research? Has this changed your has this changed your practice, either as a clinician or from a management perspective? Were you able to implement any type of policy that has affected the OTs and PTs that are actually in the critical care floors?
Brian or Katie, from a management perspective, have you seen any changes? Have you implemented anything?
The one thing that we do is we ask people to try to limit co-treats or co-evals to about 8 per month, so a couple per week. So not that it's a hard and fast number, but really, I think people do well with having like, all right, what do you mean by this? Never do it? No, sometimes if it's in the best interest of the patient, go ahead and do it. But don't do it every single time. Don't fall in the trap of, but this is my comfort zone. This is what we do. When I first started, this is how my preceptor taught me to do it. Instead, let's start by trying to keep it to just a couple per week and really think through, when is it actually beneficial for the patient to have only one treatment for that day that combines the expertise, that does not risk it of homogenizing the expertise of PT and OT, that can somehow preserve it both. And that is a hard bar to be able to clear, but on occasion the patient may need it. So that's our starting point, is just try to stick with a couple per month and use the reasoning on what's best for the patient in order to get there.
And Brian, before you stop talking, will you also, because it seems to me like you published something about a mentorship program that you guys put in place there in Baylor, didn't you, for new hires and how you try and give them opportunities for professional growth? Does that feed into this at all, or is that a separate topic?
It's a separate, that's the new graduate education program, and that's a 6-month continuing education program. It's primarily didactic. We do have some follow-up mentoring. We do ask the new hires preceptor to bring in some of those components that people learned in the education into their precepting, but they're pretty much separate.
Yeah, I just thought, because so much of the discussion about why people do this is a lack of confidence or uncertainty, and so I wondered if that program helped there, but it sounds like it only does if you have a assigned mentor to somebody that has gotten information from that they can bring back to that bedside mentoring that they do.
Yeah, and one thing we have done very recently in the last year is we've taken a good hard look at our Baylor Scott & White system ICU competency and training. And we had a very extensive, however, it was a dated model, and we tried to make it a little more intentional. We tried to edit it down, not only with the most contemporary evidence, but put some better adult learning theory behind it, and also structure how people are trained in the ICU, making sure that they have carved out time to have that precepting within the ICU, as opposed to give someone a 50-page ICU competency document and say, good luck, complete it within 30 days. We need to carve out time that's protected, where people can go in there and really start going there, but with purpose, with those training objectives. So that's one of the big things that we're actively trying to get better at.
That sounds really helpful. And Katie, I didn't mean to cut in and not let you talk about where you're at and how you've approached this too, but go ahead.
No, that's fine. It's funny because I'm laughing here because Brian's speaking my language. My leadership role is I'm an education coordinator, and I'm primarily responsible for competencies is one of the main things I'm responsible for in our system. And we've done a complete revamp of how we support professional development and growth for specialized populations and specialized units within our system. And we're still in the early stages of implementation. We've completed the competency work with our subject matter experts and gotten system-wide feedback and agreement, and in the midst of creating and building our preceptor training program so that people actually understand how to precept and guide and support clinicians, whether it's clinicians who want to pick up a new skill and step into the ICU, or new grads that didn't maybe have the benefit of that experience during their clin ed. So I haven't seen drastic change here yet in our culture. I think one of the things we have to keep in mind too is there's what's sometimes in the literature and research, what's best practice, what's the best world, and then there's real world and everyday, because healthcare is a business. And sometimes there are needs of the patient, needs of the hospital, but also needs of the care team that we have to take into consideration as well. One of the biggest things, I think we've done a good job as a whole cutting down on co-treatment here, but there is a fair amount still of co-evaluations. And sometimes that just comes out of time crunch and time necessity. It's 4:00 on a Friday and case management needs updated PT and OT notes for rehab authorization in order to get them out tomorrow to a rehab and open up a bed in the hospital. So is it the most clinically appropriate reason? No, but from patients first, patient-centered care, because the longer they're in the hospital, the worse it is for them. We need these notes to get off to get them out. Sure, these situations happen. It's the real world of real world practice. But we just had a staff meeting before this call, and I could hear the OTs talking in their little OT huddle group earlier. And one OT was passionately talking about the importance of not defaulting to co-treatment just because a tech isn't available. I touched on nursing staffing shortages earlier, because that is also a big barrier, I think, for a lot of systems and clinicians. Is everyone says, okay, I grab my nurse or I grab my patient care tech. Okay, but not all systems and hospitals have enough staffing where they can just grab another staff member to physically help them with the patient. So it pumped me up for this podcast episode today, listening to our OTs in the corners talk about making sure that mobility is not the end all be all for OT. There's other things they can offer. Don't default to co-treatment all the time, or just because they're uncomfortable with something.
Haley, have you noticed anything, or have people come up to you over the past couple of years about co-treats? The thing that comes to my mind is that I've spoken with a lot of therapists where they're upset with, just by default, it ends up they have to co-treat, maybe because there's situations where maybe it's just the evaluation and they kind of want to move away from that. But whether it's management or whether it's other forces that be, what do you say, or what advice could you give to a therapist that's working out there that would like to reduce co-treats, but they would want to kind of explain that tactfully to both management, other allied health professionals that they might be working with? What advice could you give to them?
That's a really good question, Leo, because co-treatment is really ingrained in the culture of acute care therapy. And it is so different unit to unit, hospital to hospital. Even within our own hospital, we have teams that absolutely do not co-treat, and we have teams that co-treat all the time. And that's even being in a healthcare system where our management does push the no co-treatment, and they do have some stipulations like you really should only be co-treating if the patient has an AMPEC of 12 or under, which it's hard to make cutoffs and make these decisions. But even that, I'm like, you're saying you need help. You're not saying you need an OT for their brain. If we're using an OT for just their physical presence, we're not utilizing them how they're meant to be utilized in the ICU. But it's a culture thing. And with that comes a lot of stigma and a lot of emotions. I do have people all the time tell me, I want to reduce my co-treating, but the culture is so strong. I've had friends and colleagues who have been written up or sent to management. They've had like RLs written on them because they're not a team player, because they don't want to co-treat with an OT. And so learning how to have those conversations tactfully, right? I'm not saying that I don't like you and I don't want to help you. I get like why you might want to co-treat, but let's think about what's best for the patient. I think the patient may benefit from XYZ. Here's my clinical reasoning, and have a discussion about it from a patient-centered approach and not from a clinician-centered approach. But those conversations can be really difficult. So I think that everybody having a baseline understanding is not really the right word, but a baseline thought, at least, that co-treatment may not be what's always best for our patients. And then we can have some jumping off points for discussion when it comes to particular patients. And I think that as a therapist, if you have clinical reasoning why you do not want to co-treat, it's hard, but you almost have to pick it off one by one of having those conversations each time it comes up about this particular patient and why they may benefit from more than one session, why they may benefit from separating and having more one-on-one focused and goals that are more specific to each discipline. So it's not easy. And I want to recognize that, like, all of you that feel stuck out there and feel like you're going to be shunned from your teams or your culture or written up for not wanting to co-treat, keep fighting the good fight, but just find a way to do it. And that's in everything we do in healthcare, right? Find a way to do it without alienating others, bring people in rather than calling them out.
Bringing it back to the article, I love how at the very end, first of all, it's a clinical perspective, right? It's a perspective report. And what's great is that we've got different perspectives, right? We've got from an academic side, from a PT management side, from an OT perspective. I appreciate that. What I love about this article too is that at the very end, the last paragraph, there's a call to action. So you've actually got a call to action about, as I'll just read a quick quote of it, PT and OT professionals must critically evaluate current co-treatment practices, not only in terms of patient outcomes, but also how they shape professional identity and create value within the healthcare system. So I think, when did this article come out? I think this is volume 17. Was it April earlier this year, and maybe a couple months ago?
March or April, but I think it was published online ahead of publication.
Yeah, in January, maybe.
Yeah.
Where do you foresee this? Maybe this is just a catalyst. Where could you see maybe some of the research going into the efficacy or the use of co-treatments versus not co-treatment? Where do you see that moving towards in terms of research?
Yeah, so part of the reason we wrote this as a perspective piece, and it was hard. I'm going to be honest, this took me several years and several submissions to get it accepted anywhere because there's no evidence, right? So this was a really mind boggle of like how to use existing evidence to try to weave together an argument for something where we don't have any relevant evidence that's very specific to it. So it's hard, but we wanted to have exactly what you said, a jumping off point for future research. Now, other people maybe are going to design a study that's going to look more at the outcomes related to co-treating or even the prevalence of co-treating. We don't even have good evidence for that, right? And now we have at least this perspective piece that we can reference, and we've collected a lot of the best evidence about related things such as management standpoint, the ethical considerations, the treatment considerations in acute care. But I actually want to throw this question over to Danny, if I can. Danny, you're a researcher that I very much admire and I love your work. In your opinion, how can we build upon the evidence base for this? How can we look at this in a more research-focused lens to create some evidence? If we had evidence that said co-treatment was not ideal or said it was ideal for certain populations and not others, that would be a lot easier to make statements and help guide management decisions. And we have this lack of evidence. What do we do about that?
Yeah. We need people who want to create evidence. That's one barrier, is there's only one of me, and we need other people who also want to do that, right? And that's challenging because going back to school and getting research training and then doing that instead of being involved in patient care isn't everybody's dream. But when it comes to the research itself, I liked what you said. First of all, we don't know how much this happens or where it happens. And that descriptive information is often really helpful to define the extent of the landscape there. So I think that's a great place to start. Doing that kind of work isn't easy either, because it's really about survey methodology for that. And it's really hard to get a representative sample so that you can say, this is what it looks like around the United States or around the world. So the methods of that are easy, but the execution is challenging to get the information. So that you already mentioned that, and that would be helpful. But I think within your organizations, because you all come from 3 different organizations, and this is something that you all think about and work on. And if you were to combine information from your own EMRs, because in your EMR, you have date and time stamps for therapy notes, and you could see how often those happened at the same time on the same patient. So you could, at least within your own systems, get an indication of that from EMR data if people were documenting when they went in to treat patients. And then you could also look at those trends over time, because typically you have historic EMR data, and you could look back before you started talking about this, and you could compare the amount of co-treatment prior to talking about it to what has happened since. And what you changed in the middle is the intervention there. And so what have you been doing? And this was even one of the questions I was going to ask, is how have you tried to operationalize from a management perspective the effort to reduce co-treatment? What are the specific things that you do, and when did you start doing them? And overlaying the description of your effort to teach and train your therapists to do this less on top of that EMR data that you have could be very helpful. So you need an informatics expert to help you get that data, and then you need a statistician to help you analyze that data. But you all have the data. You have all been thinking about this, and I bet you probably have research contacts that would be interested in looking at the data if you were able to get it.
Danny, are you offering your services here for that? Are you joining on the bandwagon for this?
I just did, right? I just gave you everything you needed to know. Team together.
I would say that's a great point, Danny, about the EMR and data. I think I know from us, a couple different points. If our therapists were always accurately documenting their start times and when they went into the room, but we do have a smart phrase that we have asked therapists to use when they are using co-treatment to justify, because especially for depending on the payer of the patient, that affects reimbursement and billing practices, which we do talk a little bit about in the article as well. But one of the things I also noticed, we've gone through a rapid expansion here, and with that rapid expansion, the manager for our department had asked the staff, what would be of better use to you? Hiring a PTA and a CODA to help with treatment management, or hiring another tech to help with the amount of patients who just require an extra set of hands. And he did put the caveat in there that hiring a tech affects the department's overall productivity assessments. That means you guys are going to have to make up for that extra FTE. And it was almost unanimous across the board. Everyone voted for another tech because we knew by the way our hospital had expanded and what the rising needs and the continued increase in acuity and complexity of patients since COVID, that we needed more hands more than we needed another therapist on the floors.
Yeah, and these kind of changes are great examples of what I was talking about, because you've been doing things to try and address this, and looking at what you have done over time and combining that with the data that you've been tracking, because you have a smart phrase, so you know how much co-treatment has been occurring. Sounds like a really great project, and it would be fun to help you look at that data and to identify other researchers that would be interested in helping to analyze it. The informatics support that you would need to get that data would have to come from within your institution, but the design of such a study and the analysis of that and then the dissemination of that is certainly something that someone like myself would be excited about being a part of.
So when we look back, years from now, is that this is this was the catalyst. This is the starting point when Danny got roped into doing all the all this assistance for the.
Oh, we're roping you in, Danny. You just wait. I have some big plans coming your way.
I'm just down the road, and I've already done some fun projects with people at Utah, so I'm happy to come back.
Wonderful.
Haley, you had mentioned to us also in the article, there's also a supplement. I think some people don't realize that there's a supplement also. And what information is in that supplement?
Yeah, thanks for remembering that. So we built a framework for clinical decision-making regarding the use of PT and OT co-treatment in acute care. And we started out by having this as more of a central piece of the paper, but because it's not validated or anything yet, this is just based on our clinical experience anecdotally that we created this. So we ended up putting it just as a supplemental digital file within. So a little bit tricky to find this. You actually have to open up the full manuscript, right? Not just the abstract. Open up the full manuscript, scroll all the way down, and there's a link to a supplemental digital file for the care framework. This is just, we tried to just make something visually pleasing, easy to look through to help you determine if your co-treatment use is based on clinical need and try to reduce the use that's just habit or for your own convenience. So really starting with critically assessing the patient needs, making sure that we're aligning therapy goals with the resources that we have, knowing that resources available to us fluctuate from any given moment and any given patient. And then a big piece of this also is even if you do choose to use co-treat for a patient for this particular session, you need to clearly document. This is something I think we are really not good at. Clearly document why you utilize co-treatment and why it was more beneficial for the patient than one-on-one sessions. You need to have some clinical reasoning for why you're using co-treatment. And then reassessing every session. So just because you use co-treatment last session doesn't mean that patient needs to be co-treated for all of eternity. We need to be better about rethinking every day and reassessing the patient's needs as well as the resources available to us to make sure that we're co-treating only when clinically justified, as much as able. As Katie mentioned, there are times when we know this is not going to work, but if we really try to put some clinical reasoning into it and make that work 95% of the time, I think we will see a huge reduction in the amount of co-treating, hopefully to the benefit of our patients.
Thank you, Haley. I just want to kind of, as we start to kind of close up the podcast, we're going to move into our rapid responses. So you guys haven't skipped the rapid responses yet. But just to close things off, are there any final thoughts that you all like to share? I'll just say that the times that I co-treat is just so I can hang out with my OT friends and we can con around with each other and just have fun memories. So to really justify why, and that's thank you for that last episode years ago because it did change my practice. But on that note, are there any other final thoughts that you'd want to share with our audience?
We don't want anyone to feel bad on the inside or that they're a bad clinician or they've done bad things for their patients. Again, the point of this perspective piece and this episode is to start a conversation and allow people to reflect and really critically think through why they're doing things in order to benefit the patient or optimize what we're doing for the patient. I don't want people to listen to this episode and walk away from this thinking, oh, I'm not a good acute care therapist because I do X, Y, and Z. That's not the point. Haley, myself, and Harley have all touched on various reasons why people co-treat, and it's not all of us can necessarily say or amount to the fact that we never had before, because there is a reality of practice, especially in this day and age, and things happen. So don't come down on yourself, but take away from this paper and this episode an opportunity to reflect on your practice and try to take small steps of asking and having those conversations with your colleagues. And even if change doesn't happen right away, that is usually where change happens, is just those initial conversations and those initial reflections.
Yeah, I think if I may, some of the best of those conversations that I've had with my PT colleagues have both been us coming together and saying, is this a person who's appropriate for co-treat? And then simply saying, what was your plan of care for this session? And this is my plan of care for the session. And I don't know how many times they actually don't mesh up at all. And the question's answered, we're not going to co-treat. That's been the simplest way that I have with my PT colleagues determined whether or not to co-treat. And that's really built into the care framework that is in the supplemental instruction. So I think it's definitely worth looking at. And OTs listening out there, you have such a meaningful role to play. Go in fully prepared to do it. And same PTs, same thing.
Thank you, Harley.
And I just wanted to add one last thing too. We haven't really talked about solutions for like how to get the help you need or the training you need, things like that. In the absence of co-treating, that could be another paper, another podcast. It's a big topic, but just to plant in people's minds, I always talk about, yeah, okay, you need help with this heavy maxillus transfer. Let's bring in somebody just to help with the transfer. Right? They're not co-treating with me. They're out there charting, or maybe they saw another patient. In the meantime, I got the patient up. I'm asking my questions. I'm getting them prepped. I'm doing some in-bed exercise. I'm getting all the lines and tubes ready. And then when I need help with that transfer, I'm going to pull somebody into the room just for that couple minutes that I need the transfer and then let them go. And there's a difference between asking for help, because especially in critical care, it's a team sport. It's not feasible to do this alone. We cannot do it alone. But how we're utilizing that, and whether we're utilizing people to actually do treatment and overlapping our treatment, or whether we're using them just for short pieces of assistance, is a very different story. So I just wanted to plant that seed in people's brains to get you thinking about how you might approach, let's say, a patient that is an AMPAC of 5, an AMPAC of 6, and needing 2 people or 3 people or 5 people to mobilize, how we're going to approach that differently without always reverting to co-treatment.
Very cool. Brian, any last thoughts or ending thoughts that have not already been covered?
No, these 3 are so much smarter than me and so much more, and have all of that flow experience. I'm just trying to stay out of their way. They've nailed it perfectly.
Awesome. Very cool. Danny, I think it's time to hit our panel here with some rapid responses. So I'll set up my time. We'll probably go a little bit longer than a minute because we've got 4 guests. We'll go a little bit longer and extend it. And Dan, you have a question lined up?
Yeah, we always like to start with, if you're not doing PT, if you're not working, what are you doing for fun?
Do you want one of us to answer or all of us?
Yeah,
just call them somebody.
Let's pick on individuals, because if we have all 4 of you go every time, that'll be long. Let's start with Katie, because she's first on my screen.
All right. So if I'm not, I'm probably playing with my dog, taking for walks, trying to prevent him from eating the bunnies in our yard.
Awesome.
Brian, I have a question for you. Are you a coffee person or a tea person?
Coffee first thing in the morning, and then I switch to tea at midday.
Ah, nice. Very good.
Great. Haley, what's the best thing about living in Salt Lake City?
Oh, the best thing about living in Salt Lake is the mountain access. People in other parts of the country like to say that they're close to the mountains, but I can literally run or bike from my house and be on some world-class trails. So that's the best part, is the trail access.
Awesome.
Harley, name a movie that you could quote endlessly.
Oh boy, The Princess Diaries. That's the first one that came to mind because I just watched it.
Great. Awesome.
Brian, what's your strategy in the hospital for dealing with patient code browns, which is something we've all had to manage in the past?
Screaming, panicking, looking for extra clothing, and seeing if you can just go home for the rest of the day. So basically, fear and panic.
Katie,
that's why he's in management now.
Right, exactly. Katie, I have a question for you. What's your go-to procrastination activity?
My go-to procrastination activity, scrolling TikTok. I hate to admit it, but TikTok, it's just, after using my brain so much during the day and just being physically exhausted as well. I always tell my fiance, my brain and body are exhausted from what I dealt with today. So I just need 10 mindless moments on social media. That's all I need.
After all the code browns, time to go on TikTok.
It's not just code brown sometimes either. It's all the bodily fluids.
Yeah. Harley, what's your favorite type of patient to work with?
I love geriatric patients. They are my absolute favorite to work with.
Old people
Fantastic.
are the best.
And we're at about time, so I'll ask this for the whole panel, and y'all can kind of jump in. You know you're working on acute care when?
Ooh.
Fridays are your least favorite day of the week because it's discharge day.
Yeah, absolutely. Then you have to
Following on
co-treating.
that, when your favorite day of the week is some random weekday because that's your weekend or your consistent.
It's your comp day.
Ooh.
I'd say when you're familiar with cortisol and plenty of it nonstop.
Right?
That's my version of caffeine.
I guess I would have to say when you're dealing with code browns on a daily basis.
Right? On the daily. Awesome. Katie, Brian, Harley, Haley, thank you all so much for being here for this episode today, and again, just spreading the word about how to utilize co-treatment and when not to. And thank you so much for being here with us. Thanks for the conversation. We talked a lot about conversations today, conversations you have on acute care floors, acute conversations. So thank you for everything.
Yeah. Thanks for inviting us to have this conversation and spark some further conversations.
Absolutely.
Thank you.
Thanks, everyone.
Hey, everybody.
We would like to thank Haley, Harley, Brian, and Katie for joining us on the podcast. Acute Conversations is the official podcast of APTA Acute Care. This episode was hosted by Leo Arguelles and Danny Young. Executive produced by Katie Brito and Edward Mathis. Music by Alexia Action from Pixabay, sound effects also from Pixabay. For more information about APTA Acute Care, be sure to check out our show notes for links and resources from the Academy. If you found value from our podcast, please be sure to subscribe, follow, and share with your friends and colleagues. Join us next time for a conversation with Rania Farhat about PICS. Thank you for listening, and may your shoes and scrubs stay clean today.